Hello. Hello, Yogesh. You'll just need to unmute yourself, Yogesh.
Yes, I have. Thank
Yeah.
you.
Okay, thank you. Yogesh, do you want to just try your screen
Yes,
share for a minute?
I do wish to do that. So let's do it. Are you seeing my screen now?
Yeah, just maybe just widen it. We can see your screen
You
nicely.
see it now?
That's perfect. Yeah, that's perfect. Maybe
Okay.
just
So should I just leave it at that? Or how do you want?
no, just try moving your slides up and down.
Yeah, you
Yeah,
getting it?
that's perfect. That's perfect. If you can stop the screen share for a minute, I will
Yeah.
just introduce you and then you can share again.
Yeah, right.
Okay. Yeah, we start in 2 minutes, huh, Yogesh?
Yeah. Fine, buddy. I just pick up a glass of water and come,
Sure, sure.
yeah.
Yes. Okay. We will
Yeah.
start in a second now. Yogesh, can you see the
Yeah, I could.
introduction
I
slide?
could. Yeah, I can.
Okay, good. Welcome, everybody. Good morning, good afternoon, good evening, wherever you are. So, this is the uh, academic meeting of the Department of Pediatric Surgery in East London, South Africa. And I am very delighted, happy, grateful that my very dear friend, Professor Yogesh Sarin from New Delhi, India, has agreed to be the invited guest for today's talk. I have come to know Yogesh through technology, that is through Facebook. So there are some good uses of Facebook. Um, Yogesh is currently director and professor head of the Department of Pediatric Surgery at Lady Hardinge Medical College in New Delhi. And he has lots of accolades, which include current president of the Indian Association of Pediatric Surgeons. He was Delhi State Awardee. He has hundreds of articles, multiple book chapters, one book already published, one in the pipeline, and he is patron and ex-editor-in-chief of Journal of Neonatal Surgery. He has fellowships in trauma, laparoscopy, and pediatric surgical oncology, which is his area of interest and expertise. And in his whatever little free time he gets, he loves traveling, gardening, dogs, and spirituality. And he says he is disciple of Lord Krishna, which many of you may know is one of the practical gods from Hindu mythology. So, Yogesh, you probably have seen Professor Hadley, who will remember you, and you may see some other colleagues who you have met before. But thank you very much. I will stop sharing, and you can now start sharing and give your talk. Thank you.
Uh, Dear friends, can you see my screen, please?
Yes, I can. Yeah, we can. Thank you.
All right. So I must start this topic today, what's new in the management of Wilms tumor, by first showing my gratitude to few people from whom I have learned about Wilms tumor. And to start, I would definitely name Hadley. You know, Hadley, I visited in 2009, and I learned a lot from him. And he showed me around, hosted me for a while, took me to Malawi on an aircraft. So lovely memories. And two other people I must thank for what I know about Wilms tumor today. One is Dr. Schamberg. He was the chief of pediatric surgery in Boston Children's Hospital, Boston. And he was the previous chairperson or president of NWTSG, and he's written a lot of articles on Wilms tumor in 90s and all that. And then, of course, my fellowship done at St. Jude's and my interactions and my spending time with Dr. Rao, Dr. Davidoff, Dr. Shochet. So the time spent with them also gave me a lot of things about Wilms tumor. And last but not the least, I must thank Dr. Sushmita Bhatnagar from Mumbai, who actually initiated me to pediatric surgical oncology. So with that, I start my first slide. We're going to talk about timelines of key clinical advances that have established modern clinical management of Wilms tumor. We talk about updates on risk stratification in both Children Oncology Group, that is COG, and SIOP, that is the International Society of Pediatric Oncology from Europe. We will talk a little bit on biology. I mean, I didn't have time, otherwise I would have talked about more about biological markers and genetics, but any etiology, updates on diagnostics, updates on surgery, updates on chemotherapy, updates on radiotherapy. And last but not the least, again, management in Wilms tumor in low-income countries. Next slide. Okay, so this is the timeline, and these are the 11 or 12 major events that have happened in the modern clinical management of children with Wilms tumor. Sometime around 1970, I mean, a year before or after, both the NWTS and SIOP started their first cooperative international protocols. Of course, these are not the only two consortia which should be thanked for what we know about Wilms tumor today. I mean, there are a lot of other groups. The German group eventually which joined the SIOP, the UKCCLG, which is more or less as part of SIOP, the Brazilian group, the Japanese group. Even we have an Indian group who've been working on Wilms tumor. So a whole lot of them have done a lot of research. So over the years, they realized that they have to treat these patients, as we will talk later, with multimodality and chemotherapy, radiotherapy. And they realized that the treatment may cure them, but eventually may also give them, second malignancies and other side effects. So slowly over the years, they have incorporated the molecular biology and markers also into the management. And the most important thing is that a few years back, WHO launched the Global Initiative of Childhood Cancer, in which they want, similar care should be given to all patients of at least 6 cancers in the childhood. And Wilms tumor is one of them. Of course, we all know Wilms tumor is one of the key stories of success in pediatric oncology. So we all know the clinical presentation is mainly asymptomatic, non-tender, large, palpable flak. Mothers, while they're bathing or dressing the children, they pick it up. But sure, it is always in the areas where splenomegaly is so common, it could be kind of confused with that. About 1/5 of the patients may have clinical symptoms like pain, hematuria, fever, hypertension, urinary tract infection, etc., etc. The patients with severe subcapsular hemorrhage may actually present with the rapid, it's an emergency when the patient has got severe pain and the hemoglobin falls. So workup mainly includes CBC, LFT, KFTs, electrolytes. Uric acid I've added here because we in Africa and India, we have very large tumors. And when we start preoperative chemotherapy, they may actually have tumor lysis syndrome. So we should know the baseline uric acid that they have. Urinalysis is very important if we have any issues about the neuroblastoma being its differential diagnosis, or if we're dealing with patients who already has got CKD or chronic kidney disease before, or they suffer from Denny-Trash syndrome. Chest X-rays used to be very important earlier. They are still very important in diagnosis in low-income countries, and as well as monitoring these patients when we do the follow-up. CCT abdomen, contrast enhanced CCT abdomen is very good to know the details. But nowadays, both SIOP and COG would prefer a MRI abdomen in these patients if it is available. CT thorax, non-contrast CT thorax has more or less replaced both in COG as well as SIOP the assessment of lung metastasis. But if you do not have it, you can continue doing chest X-rays in those 4 views that we used to talk about earlier. Finally, needle aspiration cytology and true-cut biopsy through retroperitoneal route. These were common with the UKCCLG group, and over the years, the SAP has now added the two-cut biopsy in certain conditions, and UKCCLG, who we believed since 90s to do two-cut biopsy in almost every pediatric renal tumor, now has started doing two-cut biopsy only in limited conditions. So the indications for two-cut biopsy, both in SIOP or UKCCLG, are more or less same as of today. And we will talk about them a little later. Now, this is very important. The liquid biopsies, both COG and SIOP has started talking about liquid biopsies. So you need the tumor, Wilms tumors, that throws in a lot of DNA and mRNA in blood and urine samples. And so they asked them to collect these samples, and they need to do at least biobanking at the national level so that they could do some research, but they have yet not become the standard of care even in high-income countries. But in 10 years' time, probably when we are going to have more and more molecular markers being involved in the risk stratification of Wilms tumor, probably we need to use them. So one of the examples that we currently have is a COG study of Aaron 1921. So we know what are the major differences between the management protocol of COG versus SIOP. COG believes in immediate surgery in all those patients where it can be done. And they've claimed that it preserves vital staging because here the patient is naive, chemo naive. It has not received any chemotherapy. So there are no chemotherapy-induced changes. And treatment is according to the real stage. They feel that the SIOP, which believes in giving preoperative chemotherapy, it reduces the stage, understages them, and maybe even these patients are getting less treatment than what is required. And the treatment is according to the tumor response, as we'll hear about it a little later. So there's a large transatlantic divide that existed. But if you would know, in last 10, 15 years, there has been a lot of convergence of ideas, and COG and SIOP are forever kind of communicating with each other. And I believe that in 10 years, they probably will have similar protocols all over globally. My slide is not going ahead. Okay, so we must understand what are the histological classifications that we use for both COG and SIOP. This is very important because there are differences between the two, because one treats a naive, chemo-naive tumor where they do upfront surgery. So we have all heard about this, favorable histology and unfavorable histology. And favorable histology has got triphasic tumor, and which could be, they could be biphasic or monophasic tumor. And then triphasic tumor, according to the element that is more predominant, they would call them epithelial predominant, stromal predominant, or blastomal predominant. And in the unfavorable histology, basically, you see anaplasia or focal anaplasia. Focal anaplasia is just 2 or 4 small rests which are there, just showing some anaplastic changes within the tumor, which may be otherwise epithelial predominant, stromal predominant, blastomal predominant. But they will not be kind of very large. And any tumor that leaves the renal capsule, goes into the hilum, and otherwise would always be called diffuse anaplasia. And if you believe in doing a two-cut biopsy and you get anaplasia on that two-cut biopsy pre-therapy, then you're dealing with diffuse anaplasia. But here in SIOP, we use chemotherapy, and the biopsy that you do, or the histopathology that is sent of the excised sample, would show something different cytology. So here we talk about stratification, or a working classification, which is low-risk tumors, which is completely necrotic Wilms tumor. I have yet to see a tumor which is completely necrotic, so I've never seen a low-risk tumor really. Then we see intermediate risk tumors all the time. So here The word regressive means that more than 2/3 of the tumor has been destroyed by the preoperative chemotherapy that have been given. So otherwise, they may have mixed type, or they may have epithelial type or stromal type. Epithelial type means that more than 2/3 of the tumor which is left is epithelial. So the difference here is, there in COG we used to call predominant, here we say type. And one more very, very important thing is that the focal anaplasia here is now clubbed with intermediate risk tumors. And as you will see in the high risk tumors, the blastomal type goes with the diffuse anaplasia, and we call high risk tumors. And why so? Because this blastema otherwise is supposed to be very, very chemosensitive and supposed to kind of regress, it's supposed to kind of get destroyed. But if the blastomal cells have not been destroyed by the preoperative chemotherapy, then probably this is chemo-resistant blastomal cells, and which need a higher chemotherapy and just more than what you probably give preoperatively, that is vincristine and actinomycin D. So that is why blastomal type is moved into high-risk tumors. So there's a difference between the two, and you must appreciate and know them. So here we're talking about the staging. So stage 1 is when the tumor is contained within the kidney. Now stage 2 is when it goes out of the kidney into the sinus, perinephric fat, adrenal, liver, etc. But it can be completely excised, R0 excision. In stage 3, we have disease which has left the kidney, but it cannot be excised completely. So we will definitely at least have a R1 excision. So microscopically positive margins, or the lymph nodes may be positive, or iatrogenically or preoperatively the tumor has ruptured, or the patient has got peritoneal implants. We know about this before. Stage 4 is, of course, metastatic disease. We all know lungs is the commonest site where it metastasizes, and liver is the second. Bone, brain are very rare sites of metastasis. And now we don't talk about CT meds, etc. Both PSYOP and COG believes that if on non-contrast CT scan, if you have got nodules which are more than 3 millimeter in size and diameter, then we know that this is probably a metastasis, unless proved otherwise on a surgical excision sample. So this is bilateral Wilms tumor. Stage 5 bilateral Wilms tumor, you must understand that a new thing that has been added is that whenever we talk about stage 5 bilateral tumors, we talk about, I'm talking about stage 4 first. Whenever we're talking about stage 4 tumors, we always talk about overall stage, that is stage 4, because it's a metastatic disease. And also we talk about the local stage. So if the tumor is contained in the left kidney, so we will say it is stage 4 overall disease, and local stage is stage 1 or 2 accordingly, or stage 3. So we always mention overall and local stage in case of stage 4. Bilateral Wilms tumor is stage 5, and we kind of stage them for individual side, and whichever side has got a higher stage, we treat them accordingly. Mind it, even bilateral tumors could be metastatic, and then we'll accordingly kind of label them. So tumor stage is determined after nephrectomy. Although there are a few articles written in the 80s and all that, we talk about staging on preoperative imaging, but that's not right. So tumor staging is determined only after we have operated and sent the sample, and as pathologists have gone through it. Risk stratification, I could have expanded on this, but I'll finish it in just few lines. Both COG and PSYOP, staging and histopathology are the most important risk factors. The next thing that comes in is response of lung metastasis to the neoadjuvant chemotherapy. Both PSYOP and COG now believe in that. Both believe in metastatic disease, we must give preoperative 3-drug chemotherapy for 6 weeks and then assess the patient. If the patients actually have dissolution of all pulmonary metastasis, then it is called rapid complete responders, and these patients are then not given any whole lung irradiation as it used to be given in COG patients earlier. COG also includes age and tumor weight, and we all know that less than 50 grams tumor in a child who's less than 2 years of age in stage 1 and not having loss of heterozygosity at 1PQ and 16Q combined, would be treated as very low risk tumors, and these patients are not given any adjuvant chemotherapy postoperatively. So COG is adding more and more biomarkers in its risk stratification and its management. So we all know about the combined loss of heterozygosity at 1p16q. Then there is loss of imprinting at chromosome 11p15 and gain at chromosome 1q12. Both COG and SEOP now have been giving a lot of importance to gain at chromosome 1q12. And whenever these patients have got any gain like this, they're given much higher chemotherapy, much more intensive chemotherapy and radiotherapy, even in lower stages. So SAP has recently, when they adopted umbrella protocol, they also added that volume of stage 2, stage 3 non-epithelial, non-stromal tumors, that is the regressive tumors, the mixed tumors, and the focal anaplasia patients. If the tumor size is still, after giving chemotherapy, more than 500 ml, they are upstaged and they are given higher chemotherapy. And so the presence of viable tumor and a representative number of resected nodules in stage 4 pulmonary metastasis only patients with incomplete response after induction therapy is also considered an important risk factor in SAP. So risk stratification of favorable histology Wilms tumor in COG, we divide them into 4. Very low risk Wilms tumor, which I've already described. Low risk Wilms tumor, that is stage 1, where there is no loss of heterozygosity, and standard risk Wilms tumor, where the lower stages, that is stage 1 and 2, have got loss of heterozygosity, or the higher stages where loss of there is no loss of heterozygosity and they are rapid complete responders in the case of pulmonary alone metastasis. And high risk are the ones which has got stage 3, 4 plus loss of heterozygosity, or if they are slow responders in case of pulmonary alone metastasis, or the metastasis in the liver, brain, or bone in case of Wilms tumor. So accordingly, we heighten up the adjuvant chemotherapy and radiotherapy. So I've already described rapid complete responders and slow incomplete responders. So we will give 3 drug chemotherapy for 6 weeks and see if the tumor, if the metastasis in the lungs have disappeared, then we'll label them rapid complete responders. If they have not disappeared, then we will call them slow incomplete responders. And again, the adjuvant chemotherapy would be upstaged. So we all know multimodal therapy is there in Wilms tumor: surgery to remove the bulk, chemotherapy to eliminate malignant cells that may have spread beyond the tumor, radiation therapy in a selected few to eliminate the risk of local recurrence. So ideally speaking, all these 3 modalities should be present in every center that treats Wilms tumor. I know a lot of centers, as I talked to Milind, have pediatric oncologists who treat these Wilms tumors preoperatively and postoperatively. But I totally agree with Hadley, who believed that is rather better if the surgeon treats. See, the chemotherapy in Wilms tumor, especially, stage 1, stage 2, or even stage 3 for the matter, is usually not very intricate, and they usually don't have complications. So about more than 80% of the patients will get that kind of chemotherapy that you can manage on your own. So you don't need to bother. Radiation therapy ideally should be present, but in case I know sub-Saharan Africa does not have many radiotherapy units, if they're not there, then we kind of alter the chemotherapy accordingly. There is a SAOP, a PODC document that was published way back in 2013, which is still the Bible of treating Wilms tumor patients in countries where there are resource constraints. Sorry, my slides get stuck every now and then. So preoperative two-cut biopsy, yeah, UKCCLG used to do it since 90s, and they went on doing till about 2016-17 when they agreed to become part and parcel of umbrella protocol of SIOP. So the about two-cut biopsies were that imaging used to have 5 to 10% errors. So at times benign lesions in SOP used to be given chemotherapy. At times non-Wilms malignant renal tumors used to be given inappropriate or unnecessary chemotherapy. It is all the more important for Southeastern countries like Vietnam, Japan, and even India, where non-Wilms malignant renal tumors actually form about 20 to 25% of all pediatric renal tumors that we see. In the West, probably non-Wilms renal tumors will be only about 10%, but we have a little higher. So although SAP and UKCCLG now does two-cut biopsy on very few patients, I still continue to do two-cut biopsy on every pediatric renal tumor, at least in my center. I know not many Indian pediatric surgeons do that. We are only about 2 or 3 of us in India who do two-cut biopsy, but I've never regretted. I've never had needle track seeding. I've never had hemorrhage. I've never upstaged the disease. So the SAWAP and UKCCLG does not believe that if you do a FNAC or if you do a cutting needle biopsy that you need to upstage the disease. But the COG still believes that if you've done any kind of biopsy, even FNAC for that matter, then probably you have upstaged the disease, and the minimum stage that you should use for this patient is stage 3. Open biopsy used to be done very often in patients where in COG in America, when they used to think that they cannot operate and remove the tumor. But nowadays, it is believed that it's not very important. So very few surgeons across the Atlantic are doing open biopsies. But SAP believes that if an open biopsy is done because the capsule is violated, and so definitely even in SAP, it will be stage 3, just like COG. So surgeons, what do surgeons do for Wilms tumor? This is a very, very important slide and very favorite slide of mine. Oh, they can do a pre-chemotherapy biopsy. They can put lines. I don't put lines in my ward, in my department, but a lot of fancy centers put big Hickman and ports and all that. I mean, so surgeons can do that. Nephrectomy, yeah, most of the textbooks still talk about radical nephrectomy. And I saw Hadley doing simple nephrectomy when he was operating in 2007 in Mumbai, and I started questioning radical nephrectomy. Most of the people talk radical nephrectomy still, and it's written in the textbooks like that. But I think most of the masters only do simple nephrectomy for patients of Wilms tumor. Adrenal sparing radical nephrectomy, yes, nowadays, especially if the tumor is confined to the mid or the lower pole, one doesn't need to kind of excise the adrenal along. Simple nephrectomy, I've already described. So unlike what is written in textbooks, which is more relevant, and it started with when in renal cell carcinoma, they started operating the kidney outside Gerota's fascia. But most of us open the Gerota's fascia and do remove the kidney and the ureters and the nodes, etc. later. This total and ablative nephrectomy is also the terms that have been used for simple nephrectomy only, which I talked about. Then we talked about partial nephrectomy or nephron sparing surgery, and we're going to talk about a lot about this later. So partial nephrectomy had indications, and one of the indications definitely was bilateral Wilms tumor, or the patient has got solitary tumor, or wherever the patient has got CKD, or if it is Dennis-Drash syndrome. Wherever you want to save nephrons, they used to do it. But since 90s, Italians and some of the Americans and the Canadians, they have been doing NSS even in non-syndromic unilateral Wilms tumor. This is something which, this flag I've raised in India, and I've been doing NSS even in unilateral Wilms tumor since 2018. And now we started a big study, which I'll talk about a little later. Bench surgery, laparoscopic robotic nephrectomy. If you go through the literature, you would hardly see any of these surgeries. I mean, there'll be just, you could count on your fingertips. I mean, those many numbers of patients all over the world. And SAOP umbrella protocol, which was kind of set out in 2016, and they started doing recruitment in 2019. They believe that probably laparoscopy should not be done. And especially if NSS could be done, then never do laparoscopy, although people have done even laparoscopic NSS, etc. But that's not really relevant. Then we surgeons do surgery for recurrence. If the patient relapses, we operate after giving the appropriate chemotherapy. We do surgeries for renal vein, IVC, atrium thrombus. Yes, I have done many times for renal vein. I've done many times for IVC also, but I haven't done atrial thrombus ever. And I reviewed the literature for Indian scenario. Hardly one or two people, or maybe a few people in TMC, that is Tata Memorial Center in Mumbai, as well as AIMS Delhi, they may have done just a couple. So we haven't done too many atrial thrombus patients. Probably they die before they reach us. Pulmonary metastaectomy, this is very important, more so in SAP, because if there are only 3 or less than 3 metastasis, you can go in and resect them, and you don't need to then upstage the chemotherapy and radiotherapy. Oh, I'm just showing you some of my slides, and this patient has a very large tumor. This is the kind of the Wilms tumors we get in Africa and India. Yeah, very large tumors. And if you would see the non-CT scan here, if you would see there's a lung metastasis sitting. So what did I do? I did a thoracoabdominal approach, removed the tumor, and this is the diaphragm open, and the lung nodule, which you can see here, was also excised. So I did that in one sitting. Oh, these are the slides which I've begged from Sharon, if she's listening. These are where we have actually opened the retrohepatic cava, and we are trying to remove the thrombus. And in this side, this is the atrial tumor. I mean, I believe Alistair and group, Miller and group, they have done very large numbers. I think we're next to probably only St. Jude's in removing all these atrial tumors, and I have no experience about it. We know the steps of radical nephrectomy. Radical nephrectomy, I personally think, should stay till the textbooks, but still people talk about it. The most important thing is when you open the abdomen, you take the ascitic fluid and send for cytology. This is something which, again, I learned from Hadley. If the cytology comes positive, then you know that this patient is at least stage 3 disease and treated accordingly. We all talk about ligating the renal artery and vein first because we feel that that way we do not kind of throw away the metastasis. But trust me, with the large tumors, as I showed in the previous slide, you cannot probably ligate a renal artery and vein. And somebody from Africa has written a good article, which is tumor delivery technique. And that's exactly what I do. I open the gyrotous fascia and mobilize the kidney all around, and I hit the pedicle the last. And I have never seen more or less, recurrences. In fact, I haven't seen any ruptures in this technique, and I haven't had recurrences for too long, touch wood. The nodes have to be removed. The locoregional nodes, this is one of the reasons of failure of surgery. And now we know that we have to remove at least 7 locoregional lymph nodes, as we are taught by COG and SAP. But trust me, at times, they're not even 7 lymph nodes. I mean, you probably would pick up some nodes, which you obviously know that they are not positive. So one must palpate renal vein and IVC because it's very possible that you may have missed the cable or renal vein thrombus on imaging. That's very important. So with good imaging, intra-op inspection of the contralateral kidney is no more mandatory. In last two decades, we have not been using. People used to use titanium clips earlier, no more recommended. So if there is tumor which is going into the liver, one has to do a complete en bloc excision. And then if you do that, it still would be stage 2 if you have removed and left no microscopic disease behind. Ureter is ligated as low as possible. And trust me, I have actually used Ligashore to just do it. I will not even put a ureter at the lower end. But the most important thing is written in the red in my slide. Avoid tumor rupture. The moment you rupture a tumor, you have actually ruined the child. The chances of this patient having recurrence are very high. And the results, which should be in the range of 80-90% overall survivals long-term, would come down to 40-50% overall survivals, even if you give the most intensified chemotherapy and blah. So please do not do tumor. It's not a tumor that should, very large tumor comes, it shrinks a little after chemotherapy, and you ask your resident to do it and he ruptures it. No, that's not acceptable at all. You have to operate these patients in your own hands or probably under guidance. A lot of incisions have been used for radical nephrectomy, but still I would probably do only one suprabolical transverse. But if I have to resect some metastasis along, again, which I repeat, should be less than 3. I mean, if there are more than 3, both the lungs are studded with metastasis, obviously you don't touch this metastasis. And cardiopulmonary bypass, as I said earlier, I have no experience. Bench surgery, I have no experience at all. This is, I already said, you don't need to remove the adrenals because adrenals are involved only about 4% of Wilms tumor, even if we include all the upper pole tumors along. Partial nephrectomy, yes, as I said before, these are the indications that we always use: bilateral Wilms tumor and unilateral polar or peripheral small tumors less than 4 centimeter, where at least half of the kidney could be spared after the tumor resection with a margin of. So we all started with, saying that we should do partial nephrectomy only if we could save 2/3 of the kidney. That's about 75%. And now we come down to articles which say even if you could save 20% of the kidney, go ahead and do partial nephrectomy. And I believe that because that Atarian group may not have done too many surgeries, but they have done long-term, longitudinal, lot of studies and written a lot of papers on the few, say, less than a dozen patients that they've done, and they've shown that no recurrence occurs, and it is good to save that 20% also if you could. So contraindications, there are a couple of contraindications even now. Anaplasia, if you have got anaplasia on the biopsy before, you will never do it. If perioperative rupture is there, or if you cause intraoperative tumor spill, you will not do it. If tumor is infiltrating into, if the tumor has basically gone outside kidney, the lymph nodes are positive. If there is a thrombus in the renal vein or IVC, you will not do partial nephrectomy in these cases. But there are a few indications which I use, which others don't use. I would even operate in a unilateral Wilms tumor, even if there are multifocal tumors or there are central tumors. I have even operated in patients and done NSS where there was a tumor which was actually dipping into the calyx. So I would give a margin of a free margin of say about 5 millimeter, and still would close the calyx and save the kidney over a DJ stent which was removed. So as I said before, we started with that we should save at least 2/3 of the kidney, and now we are approaching that. We may even, if we could save about 20% of the kidney, we should do NSS. So bilateral tumors, Rickham in 1957 was the one who said that if you have bilateral tumors, you remove kidney, which is more involved, and do NSS on the one which is less involved. But the paradigm has now shifted to bilateral NSS, and one should one should do bilateral NSS. Avoiding total nephrectomy at initial surgery is advised for bilateral tumors in the umbrella protocol that SAP is now using. So these are some of the examples of bilateral Wilms tumor that I have done. If you would see, of course, all of them are given preoperative chemotherapy. There's a very large right-sided tumor, and there's a central tumor in on the left side. If you really ask me, I know Hadley would have done bilateral nephrectomies on these patients. When I went to his department, there were at least 6 patients who had bilateral nephrectomies waiting for the renal transplant. But I won't do that. I would still excise both sides, and this is the surgery that I've done. So a very large tumor, but I still could save the upper pole, and this is the upper pole. And this is the central tumor that has been removed on the left side. This is the excised specimen on the right side, and this is the very small excised central tumor on the left side. So I would do bilateral NSS in any case that you send me. NSS is non-syndromic. This is very controversial even still, and metachronous bilateralization, less than 2% cases, trauma to the only surviving kidney, hyperperfusion nephropathy in the long run. And, extrapolating data which is available from renal cell carcinoma, if you do partial nephrectomy in adults, then there is diminished risk of cardiac related events, improved erectile function, and decreased risk of anemia and osteoporosis. So the causes, as I said, Italians, they were the first ones to do. Now we have got about 310 patients already reported worldwide where we have done partial nephrectomy on non-syndromic unilateral Wilms tumor. And this is the paper which I've published very recently. We have done a systemic review, and I've worked very hard on this paper, 7-8 months, because people won't listen to me. People won't agree with my way of doing things. So I've written a paper on that. So this is the classification of NSS, which Borzanski had said in 2014, and now it is included in the umbrella protocol. So basically, you have to mention in your OT records whether you have done a partial nephrectomy, which is NSS-A. If you would see, there is some kidney also, normal kidney removed with the tumor, or you have done enucleation. So you are not cutting any normal kidney along, and you're just going into this plane and getting this, kidney out. So this is NSS-A and NSS-B, and then you have to talk about surgical resection margin, pathological resection margin, and remaining renal parenchyma. This is the only way when we start doing NSS, we'll be able to compare the results of one department to the other. So one must do this. So as I said, that we all started saying that we should at least have 2/3 or less than 50, and now slowly we're doing even when we can remove less. So this is another patient there, which I'm showing the CCT scans where I have removed. The umbrella protocol recommends that NSS in non-syndromic unilateral Wilms tumor should be done only if the tumor is less than 300 ml and lymph nodes negative status is there when substantial remnant kidney function is expected. But having said that, a lot of people have done NSS in non-syndromic unilateral Wilms tumor when the tumor volume was more than 500 ml after giving chemotherapy. I have done on a patient maximum when it was about 348 ml. Yes, lymph node status, negative status has to be known. So even in Durban, they had a frozen section facility. So you have to send the lymph nodes before you started doing a partial nephrectomy. And if lymph nodes come positive, then you have to go for total nephrectomy or ablative nephrectomy or simple nephrectomy, whatever you call it. So we are doing now in India a prospective multi-institutional study on NSS in non-syndromic unilateral disease. And we've got 8 institutions which have been enrolled, and we are going to, by the formula that we have worked out, a minimum sample of 88 patients that will work out in 1 year. So this is a little crowded, but this is the management algorithm. So basically, we would listen to NSS and we will have less than 300 ml tumor volume patients. And we will send lymph node biopsies for frozen section. If they're positive, we'll go total nephrectomy. If they're negative, we'll go for NSS. And intraoperatively, we will also send a surgical margin to know whether it is positive or not. If it comes back as positive, we can either cut more kidney one slice, or else we can decide to do completion nephrectomy, that is removing the rest of it. Now, this is not considered as a tumor rupture, and you may not give radiotherapy to such patients postoperatively. But few people may think that by doing this, actually, if a positive margin comes and then you're resecting it again, you're probably upstaging the disease to stage 3 and treat it accordingly. So these are a few of the slides where I've done NSS in a unilateral Wilms tumor, very large tumor. I've given chemotherapy, only 15% of reduction in size. This is another patient where the reduction of size was hardly 4%. So it's very hard to say which patient will have chemo-sensitive tumor or which will shrink or which will not shrink. They all shrink, but the degree to which they will shrink could be 4% to 84% in my series. So here again, these are the slides which I've shown you earlier also, upper pole tumor. We have done tumor delivery technique, which the credit goes to some African surgeon, and when we have excised it. This is another patient where we have a large tumor. It reduced significantly, and we operated. All these patients also have DMSA with the split renal function before and after surgery. So this is another patient who's got a large upper pole tumor, and we have gone in and excited. If you would see in this slide on my right upper hand, you could actually see the tumor going into the pelvis. So what we do is we will take a margin, a free margin of about 5 mm, and then close that rest of the pelvis over a DJ stent. And this patient never had recurrence. This is about 2 years old patient. The surgery was done about 2 years old. This is another patient where it's a very large tumor. Obviously, they will say, well, go ahead and do nephrectomy. Yeah, but it shrank so much. It shrank 82%. And I went ahead and did nephrectomy on this patient. This patient also had a very large central tumor. Obviously, a contraindication, but we go by the SIOP standards. But I gave chemotherapy, it reduced in size, and then I operated. Uh, the ischemia and peripheral nephrectomy, partial nephrectomy, very important. Cold, warm, zero ischemia. I do all zero ischemia. The Miller et al. Have done a lot of these surgeries, and they believe in doing cold ischemia. But trust me, not any major intra-op hemorrhage occurs when you do partial nephrectomy, and one doesn't need to really go in for cold or warm ischemia. Warm ischemia is definitely not recommended because the vessels in small children are very small, and if you would put even a non-traumatic clamp, there could be intimal injury which could cause later issues, thrombosis also. Positive surgical margins in 1990, my boss Schamberger said, "Oh, positive margins means recurrence and it all." But it has now been proved if even it's a positive margin, if you give standard chemotherapy, nothing happens and recurrences don't occur. But sure, if you have messed the whole thing, done major kind of rupture, then probably you messed the patient itself. This is a slide from Warman. Now, the large tumors, as we see in Africa and India, probably cannot be ever excised by laparoscopy. So this is where they have given us that in case on your CCT, if the medial margin of the kidney harboring the tumor crosses the margin of the vertebral column, you will not be able to get on to the renal pedicles, so don't do laparoscopy. Mind it, when we operate open surgery, then we can actually hold the tumor in our hand and everything can be very well handled. But in laparoscopy, there is no way you can do the tumor delivery first. You have to hit the pedicle first, and in laparoscopy that cannot be done, and the chances of hemorrhage are very high. So laparoscopy probably can be done only for very small and is recommended by SIOP in small central tumors, but I would not advise anybody to do laparoscopy as of today. So failure of surgery occurs when you don't do the lymph nodes well, you cause intraoperative spillage, or you do unjustified incomplete resections. Nobody is as big surgeon as Hadley. So don't see Hadley and say, oh, next time I'm going to excise that big tumor. Hadley can do it. Maybe I and you can't do it. So we know indications of neoadjuvant chemotherapy. These are last one for me slides because Milind asked me not to do too much of chemo and too much of radiotherapy. Last few slides before I close up. So we all know that bilateral Wilms tumor, or wherever there is bilateral nephroblastomatosis, or unilateral Wilms tumor with contralateral nephroblastomatosis, or patients with WT predisposing syndromes, or especially when the patient already has CKD, or whether the patient has got Danny-Drash syndrome. And in COG, intravascular extension into IVCs above hepatic veins. And in our countries like ours, where there is an inoperable tumor, where we feel, no, we should not go in. The gut feeling, the first thing that you come to my mind, maybe I'll rupture it if I operate. Don't do surgery straight away. Give them chemotherapy. So we all know about the neoadjuvant chemotherapy. Localized disease, we give 4 weeks chemotherapy of 2 drugs, that is extinomycin D and vincristine. Metastatic disease, we give doxo also to 3 drugs for 6 weeks. For both COG and SAF in bilateral tumors, we give vincristine and actinomycin D for localized disease. If the tumor does not shrink within 6 weeks in SAOP, they move on to carboplatin and etoposide. But no time you will give chemotherapy more than 12 weeks. If the tumor does not shrink 12 weeks, then there's something else that you're dealing with. Probably it is a stromal predominant or stromal type tumor. Probably it's a benign tumor, something else which you're missing. And people used to say never biopsy or never give chemotherapy to less than 6 months. But there are some indications. If the patient has got stage 4 disease in less than 6 months, then or the patient seems to be having an inoperable Wilms tumor in less than 6 months, then also you will do a biopsy as well as do preoperative chemotherapy. So this slide is too messy, but I will not go into it. So basically what I'm trying to say, as we move on from very low risk or low risk to high risk tumors, we go on adding more and more chemotherapy. Majority of the patients, even today, even in low income countries like ours, will have only two drugs probably in the adjuvant. Maybe we need to add doxo. SAOP has reduced doxo doses in their umbrella protocol because it's supposed to be cardiotoxic. But when we reach stage 4, and especially we are treating anaplastic tumors, then we need to give very highly intensive chemotherapy. And please do not treat this patient in every center. You must have only 1 or 2 centers in the entire country where you can refer these patients. Otherwise, the results will be bad. These are protocol radiotherapy guidelines. I think I'll skip this. The only line I'll say is that COG gives less radiotherapy than SIOP. And now in the fast complete responders, they will not give whole lung irradiation or WLI in COG, which was not the trend when we were students. So whole abdominal radiotherapy has to be given
Yogesh,
instead of
sorry,
fast
about 5 minutes, please. Thank you.
Yes, I'm going to finish in 5 minutes. So if they are peritoneal implants, or if, as Hadley suggested, send malignant cytology and ascites and it is positive, then probably you need to give a whole abdominal radiotherapy. In the best of centers in India, I have sent my patients to AIMS New Delhi, and still, in spite of doing all the precautions that you do, patients have landed up in having, CKD and eventually died or needed a renal transplantation. So if you're giving whole abdominal radiotherapy, you have to be very, very careful. This is a very important slide. I've not talked about the biologics because Milan said we'll not have too much time, but potential targeted therapeutic applications are very much in the offing. So migrating RNA therapeutic modulation, the WT signaling, and P53 specific biologic binded P53 positive tumors are anaplastic tumors. And these are the ones which, so they're going to come out with drugs where we probably will be able to hit them with drugs with the immunotherapy, where we probably don't need the other 3 modalities. So it is very possible in 20 years' time, nobody will be operating, nobody will be giving chemotherapy or radiotherapy to these patients, and these targeted therapies would be worked. Retinoic acid can be given even today. If you see a tumor on one side and nephroblastoma on the other side, then retinoic acid is supposed to be kind of halting the nephrogenic rest to turn into Wilms tumor. So it is very important. So outcome and prognosis, we all know it is very good. Even in pulmonary alone metastasis stage 4 patients, it is very good because of the newer chemotherapeutic regimes, etc., that we have learned. These are last 2-3 slides. Challenges in lower or middle income. We all know our patients come late because our parents don't recognize this. Our local workers don't recognize it. We have shortage of almost everything. Human resources, chemotherapy, radiotherapy is not there. And we do not have good specialized, not many people can be, trained under Hadley maybe. And we do not have registries, we don't have data collection. So all that actually affects us. So patients are malnourished. That's very, very important. That's something I learned from Hadley again. Or the patients in Africa, as I saw, they may not only have malnourishment, Wilms tumor, but they may have even tuberculosis and also HIV positive lung. So there's a lot of problems and we need to kind of deal with them. So we need to have a comprehensive registries. We should try to make early diagnosis, adapted treatment. That Bible, as I said, for the LMIC, that is the adapted SOP PODC regime, that must be used even now, and nutritional programs, give them locally available calorie dense foods and fortifiers. Don't talk about things which they feed in USA. Talk about what grows in your backyard, and give those to the patients. Family education programs, very important. Twinning programs have succeeded. A lot of people from Europe have been, or St. Jude's from USA has been hand-holding countries in Africa. Clinical trials which are locally relevant is very, very important, and prioritizing the resources. If you can't say anaplastic tumors, don't bother about them. Just give them palliative therapy, but save all the favorable histology palliative. That's very, very important. Palliative care is important, where you kind of give up and just tell the parents to take them home and take care of the patient. So this article, I'm not going to talk about it. This article must be, printed with each one of you, because it runs what you should be doing in Africa. And very simplified chemotherapy schedules. They have even given a surgical staging that even if your pathologists are not good, Let the surgeon say that he's removed the tumor which was contained in the kidney, that is stage 1, which was outside kidney, it was stage 2. And if he could not excise the whole tumor and he thought that there were major lymph nodes there, just believe him and give stage 3 chemotherapy. And obviously, see, this chemotherapy is just 3 drugs and very simplified. So we must give this. So this is very important. I've already talked about this surgical stage this paper talks about. Social support is very, very important to prevent treatment abandonment. You must give dharamshalas or some areas where parents could come and stay when the patient is getting chemotherapy. You should give them even money for their transport when they have to come for chemotherapy schedules. So that kind of handholding is very important because patients are very poor and they must be helped. So carry home messages, use one of the 2 philosophies, whether you like COG or COP, they give same results. Avoid intraoperative tumor. If you could just take one message home, just take that. When local overall survivals go beyond 90%, start focusing on long-term morbidities. Mind it is not 90% is not for USA. My result is more than 90% 4-year survivals, So you can do it. I mean, if you know how to do it. Learn and perform nephron sparing surgeries. If anybody wants to learn NSS, just give me airfare, put me in any small little dingy room and I'll come and teach you nephron sparing surgeries, or you come over to my place. Avoid doxorubicin and pulmonary radiotherapy if feasible, and take care of malnutrition and other comorbidities. Hadley, thank you very much for teaching me that. And the tumor markers and targeted genetic therapies are on the anvil, and Millen physicians have to learn that biology and the biomarkers in coming years. Thank you very much. And I'm going to stop sharing my screen. I have taken too much of time, but I had to teach what I thought is important. Thank you so much. I'm ready to have any number of questions.
Thank you, Yogesh, for a comprehensive talk about basics and sort of recent advances and controversies in the management of Wilms tumor. I've got at least 3 experts. I need to get their opinions about it. But before that, I'll just make one comment. It is really not feasible for us to refer all the patients with Wilms tumor to one center in South Africa because it won't be manageable. Then transport will be impossible. And thirdly, at each center, there are trainees who need to learn this basic operation and how to look after these patients. That's number one. Secondly, I understand that Prof. Hadley and Durban group and you give chemotherapy on your own, but I think that's not the setup most of us deal with. Our patients are primarily managed by pediatric oncologists, and we are actively involved in the surgical management. And also for the juniors, trainees who are here, nephron sparing surgery for unilateral Wilms tumor in non-syndromic patients is not for everybody. It is after you have mastered the other things and you have learned nephron sparing surgery, only then you can talk about it. So, Yogesh,
Can I very
you can make a
briefly?
quick comment and then
Yeah,
I need
I
to
can
invite Prof.
briefly.
Hadley.
Yeah, I'll make briefly comment on all these 3 comments of yours. Okay,
Yes.
first is whether we should have centers. Fine, I agree with your statement. No issues on that. But then it is not right that somebody is operating a patient in Delhi and finds out excuses not to have radiotherapy for this patient. If I operate a patient, I involve an NGO, even a corporate, very expensive hospital, I manage and I book my radiotherapy suite on the day I do surgery so that I know I have to give radiotherapy to if histopathologist dictates me. So on the 10th day or not later than 14th day, so I must give radiotherapy. So it's not right. I mean, somebody is operating in cities like Cape Town and do not give radiotherapy for whatever excuse. So that's my comment number 1. And number 2 is, yes, not everybody can do NSS, but everybody should learn NSS because there are a lot of papers now which are available which say, okay, you may not have end-stage renal disease, but there's a very high chance that you will have a CKD and you will have hypertension that will need treatment if you would do a completion or a total nephrectomy on one side. So, and even a meta-analysis from India, a RCT is, a lot of meta-analysis are available. And RCT is also available from India, which is just very similar what I'm saying. So the third comment was, I forgot.
Yeah, okay. No problem. See, we in South Africa, we follow almost like a modified SIOP protocol, except in Cape Town, they still do COG. But I must now invite Professor Hadley, who has been patiently listening. Prof.
I,
Hadley,
I, I
please
would
your comment.
wish I could see Hadley, he could put his video on. I am very sorry to say this article, this talk of mine is dedicated to Hardy Hendren. The man I call myself Eklavya. You will understand, Milind, what I say, Eklavya.
Yes.
I grew up reading his articles and drawing those diagrams, and he died. So Hadley is one guy who has been my. I think there are only about two or three teachers globally that I actually had, and Hadley has similar personality, very aggressive, egoistic. We are similar. So I would love to have comments from Hadley, even if they may be, hitting me below the belt.
No, he's
I,
there. Yes.
I'm not sure that I appreciate being called aggressive. I thought I was positively avuncular. That was a great talk. And Yogesh, thank you very much indeed for all the nice things you said about me. But it was a good talk and a good update. What bugs me considerably about global affairs and Wilms tumour is that the rich countries, the high-income countries, like to talk about low-income countries or low and middle-income countries without realizing that within even high-income countries, there are low-income populations.
That's
and we know that particularly in South Africa, where we've got classical first world medicine in some centres, and then we've got the most appalling healthcare in other centres. So we've got to cut our suit according to our cloth. And in practical terms, pediatric surgeons should be very proud of the fact that they've led the field when it comes to biomarkers and the genetics of tumours. But these studies are not available to the patients of Africa. I mean, I can't, perhaps they're doing them in Cape Town, I don't know. But if you go to Chad and ask them how many of their patients have got loss of heterozygosity, they look at you as if you've come from another planet. And similarly, MRI, you would have to give most of my patients an anesthetic to get an MRI, and that makes it a very invasive investigation. And I can get just as much information from a CT scan. But many centres in Africa are having to work with just ultrasound, and we must take their problems into account when we're designing protocols that are going to be useful in the far-flung corners of Africa. I applaud your acceptance of looking at ascites for malignant cells. When I presented this in Geneva, they thought I was mad and that I had no right to treat these patients as stage 3, but now they've come around to our way of thinking. I wanted to make a comment about the incision that should be used for taking out a Wilms tumour. And in Africa, I've always followed Hugo Hayes' dictum that the incision should extend from Dakar to Djibouti, and you should make the largest incision, because if you do not have quality imaging, you must inspect the contralateral kidney. If you do not have quality imaging, you must palpate the inferior vena cava. And these things are an important part of the operation. I don't know whether your memory is failing you or mine is failing you, but I've only ever had one patient who had bilateral nephrectomy, and that was sequential, who had bilateral nephrectomy and has since been successfully transplanted. But for all the people listening throughout South Africa and through other countries in Africa, I would suggest that you look to the SIOP Wilms Tumour in Africa cooperative study, where they are trying to gather data about the way that these children present in Africa, what facilities are available to treat them, and so that we can draw up meaningful protocols for their management. Because at the moment, you've got countries like Sudan with an overall 2-year survival of 11%. So this is not a problem that's been solved. It's a problem that still needs to be addressed. Thank you, Milind. Sorry to take up so much time.
No problem, Prof. Thank you very much.
I would not comment anything to Larry, not because I've learned so much from him, not because when I was his guest, he made me fly a plane to Malawi. but because I actually believe every word that Larry said. The only comment that I like to add here is what I see in India is that they would get a tumor, and the same department at times would use COG and at times would use PSYOP technique. I mean, that kind of mixes the results, and then I cannot compare my results with COG or PSYOP. So what I feel is we have large tumors in India and America, in Africa, and so we must all use PSYOP, and there is no problem with that. And PSYOP very early in 70s itself proved that the size of the tumor is not dependent on the rupture, But I think, sure, the larger tumors rupture more. If you give chemotherapy, they shrink, they become, much less prone to rupture. So we must all use PSYOP across the board.
I couldn't agree more. I think that's if there's a learning point, I think that in Africa the PSYOP protocol is appropriate and primary surgery is potentially very dangerous.
And Larry, what I was talking about is that 7 countries they're doing. In fact, the preliminary report has been already filed. We have an article where they have improved their results a lot by the twinning program and what they have learned from PSYOP. Yes.
I think for the juniors listening, I think the last 2 or 3 sentences were absolutely critical to remember for good, especially if you are practicing in lower and middle income countries. I will invite Professor Bob Iqbal, who is a professor of pediatric surgery in Stellenbosch University. And Bob, please comment, including your experience about MRI for nephroblastoma. Bob?
Yes. Hi, Mel. Can you all hear me okay?
Yes, thank you.
Yes, this radiologist decided about 10 years ago to invest a high amount of money and buy a very sort of sophisticated Philips MRI machine, 4th generation, which produces fantastic images similar to CT scan, best CT scans that is available. But the problem is that to give them anesthesia and then obtain these images. But the positive point is that it can be repeated again and again and again. Sometimes we do 5 MRIs in a single patient because we are not particularly worried about the radiation issue. And many occasions, let's say in the past 10 years or so, there has been sort of I don't know, we call it a revolution, but rather a evolution of MRIs where they can do diffusion restriction of the tissue, which can predict whether the tumor we're dealing with has got high nuclear content or not. And we've worked with them for a while, and we get a reasonable correlation of 0.4. So it can help us identify high blastema type tumors, a high risk group. And this would be the 3 main improvement to CT scan. First is the fact that images are as good as CT scans. Second, we can do the imaging over and over again many times without risk of radiation issue. And this newer diffusion restriction that it might change the chemotherapy before even doing any biopsy, etc. Thanks, Milan, for letting me speak.
I will add one more advantage of MRI, which is rather important, is that if your patient has got multifocal disease, so to differentiate whether the contralateral kidney has got hyperplastic nephrogenic rest or is it actual Wilms, there also MRI is much better than the conventional CT. But having said that, I find very difficult to read MRIs myself, and I would be happier to rather do CT where we do not need to anesthetize. I have lost one patient in MRI suite for some other condition, and I'm not too great a fan of doing MRIs even in neurological conditions like when I deal with encephalocele and meningocele, etc. So I would still stick on to CECT, but I think everybody should know that both SIOP and COG now say, and SIOP is of course doing that study where they will be able to predict the histopathology after having given chemotherapy, which tumors are they dealing with before they even go in and operate.
If I might chip,
Please,
chip in, Milind.
Yes, please.
I'm frightened about doing a single MRI in a patient who has to have an anesthetic for it. And to do repeated MRIs, I think the anesthetic risk exceeds the risk of radiation. So for me, for follow-up, I'd prefer ultrasound, and for diagnosis and perhaps reassessment after chemotherapy, I would prefer to do a CT scan. And I think that's more likely to be available to people in Africa rather than sequential MRIs. Sorry to butt in.
No, agreed, Sir Larry. Trust me, my students are here and they know that I don't like the word sir. I don't let anybody call me sir, and I don't call anybody sir. But you are one of the few people in the world I would add that word sir. Sir, I agree totally.
Thank you.
Well, you would be the only one in the world.
Thank you. Now, I just wanted to bring that point out because Bob is very lucky to have a radiologist or a group of radiologists who are very keen on MRI. And that is something for juniors to know, that there are few things which are positive about MRI, but obviously we have noted the limitations of the MRI. Unfortunately, Dr. Derek Harrison couldn't wait because he had another meeting at 6 o'clock. But I see Dr. Seo Hwa Chung from Johannesburg is here. And Seo, can you just make few comments about your research work? Seo, can you hear me? I don't think she hears me. Yogesh, we have about 5 maximum minutes. There are questions here in the chat box. I think one important question is, if the lymph nodes are not visible, what do we do? The follow-up to that question is, there were lymph nodes pre-chemo, but they disappeared after chemo. What do we do? So I think if you can answer those questions.
It is very important. So you see, both SAP and COG says that you must take out 7 local regional lymph nodes.
Yes.
You know, even if they look insignificant, please remove them. So send at least 7 nodes, because if you have to kind of print a paper, compare your data with others, this will be something that you will pick up. So please pick up 7. Now coming to the issue of that we've given preoperative chemotherapy and the lymph nodes are disappeared. So what happens is the lymph nodes just don't disappear. They become smaller and they are necrotic. Mind it that if the lymph nodes are necrotic when you have sent the specimen, then also it will be stage 3, because that means that the tumor had already left the kidney and had spread locoregionally, and this patient has to be treated as stage 3. If there are lymph node positive, obviously it is stage 3, but it doesn't happen that there was significant lymph nodes on imaging, which you thought they'll come positive, and now they are not there at all. That doesn't happen. So there will be some nodes still there. If they're necrotic, they're still stage 3. Now, this differs from if there is a necrotic fat in the sinus, etc. Earlier, SAP used to stage it to stage 3. Now they believe that there is no point upstaging it to stage 3, treat it as stage 2. If the fat and perineal fat, etc., in the sinus, etc., they are necrotic. So they are still treated as stage 2.
Okay, I think there is last question we can answer from I don't know the name. How do we address a patient who is classified as stage 1 but develops lymph nodes, like malignant lymph nodes on follow-up, and when no more lymph nodes were left in primary surgery?
No, it's very possible. Recurrence and relapse can happen in the lymph nodes which were kind of not seen by your eyes on the theater, on the surgery, and they became positive later. So remind it, recurrences can be either local or distant sites, or it could be combined. So it's very possible that you may have a local recurrence which is not because of that you left some tumor, but that may have come up in the lymph nodes. But that would happen only if you have given less than optimal adjuvant therapy. If you have given less chemotherapy, or the patient has not been taking chemotherapy well, or you have been compromising chemotherapy because this patient, after giving chemotherapy, has been going into febrile neutropenias, and you've been reducing the dose from 2/3 to half to 1/3. In those situations, only this patient will have this kind of scenario that you're describing. As I said, my results in Delhi now, with all the limitations that I have, are as good as the West. I can say that very, very proudly. I haven't ruptured tumor for a long, long time. The results are very good, and my results now are kind of people are prying on it because I do NSS, so I'm always under a telescope and microscope. So I can't be lying.
I think
So,
Yogesh, you are probably a bit ahead of time, and the nephron-sparing surgery for unilateral renal tumors in non-syndromic patients is going to be a norm. I doubt whether in 10 years' time we will be doing even simple nephrectomies. For shortage of time, I would like you to now your
Milind,
concluding message.
let me make a comment here.
Yes,
You have been doing NSS for bilateral tumors. So you've been
yes,
taking the patient in and doing NSS on 2 kidneys. Why can't you
correct.
do it on 1
No, no,
kidney?
absolutely. That's what I said. Is in 5 to 10
And I
years'
said,
time.
as I said, okay,
Yeah,
don't even pay me airfare. Now on, I'll save some money and keep it separately.
yeah.
Anybody who calls me, I will come on my expense and teach people in NSS, in Africa, or wherever I'm called.
Yes. Okay, Yogesh, I think your final message in like 30 minutes, 30 seconds.
2, 3 messages. One, there are protocols which are made, and there are protocols which have been adapted to low. So please follow them. Follow them in true spirit. 2 is avoid tumor ruptures at all, and always, always, always give pre-op chemotherapy to these patients. And in your country, don't forget the comorbidities and malnutrition. Take care of them. When I was with Hadley was so much ahead of times. Yeah, he was doing a PhD thesis on nutrition in Wilms tumor. I repeated the same in my department also when I came back. So, and that was almost 15 years back. So I think nutrition is something, and hats off to Hadley, who was treating Wilms tumor, HIV, tuberculosis, malnutrition into the same single child, where parents were not there in the ward. They would abandon them and go away, and this child would get all the treatments. Larry, I bow to you, but boss.
Thank you very
I'm
much.
flattered, Yogesh. Thank you very much indeed.
Prof Hadley, you can have 2 beers today instead of 1.
And you know why I'm doing this? Because I wish he calls me again and we're flying plane to Malawi all over again.
Yeah. Thank you, Yogesh, for your wonderful talk. And I think you have covered it nicely, and nice discussion and very sound advice. And I will make the recordings available on various platforms for those who couldn't attend or there was problem with their bandwidth. And in the next month, second Tuesday of April, Dr. Rasik Shah, who is a pioneer laparoscopic surgeon in India, Mumbai, India, who is a close personal friend. He will be talking about surgical management of vesico-ureteric reflux. So thank you all who could attend today, participated, and thanks Yogesh once again. Till we see you next
Milind, could
time.
you make a copy of the chat and send it me across, please, if you don't
Yes,
mind?
I will share the Google link to the recording. Okay.
No, I want the chat because I couldn't read through.
Yes, you will
If
should
there's
be
some
able to
more
see the
questions,
chat.
maybe I
You
will
should be
listen.
able to see the chat in the recording. I believe so.
Thank
Yeah.
you so much.
Okay. Thank you.
Bye.
Bye-bye.
Okay,
Bye.
Bye to
thank you,
you.
Milind. Okay, bye-bye. Bye.